As you will agree with me, we are not only treating a disease called myeloma, we are treating patients suffering from multiple myeloma. And therefore, of course, it's important to try to deliver the treatment at the effective doses, but whilst maintaining the quality of life. So therefore, it is of utmost importance to do and to make every effort to try to balance the efficacy and tolerability. So in other words, sometimes dose modification can be needed in order to improve this tolerability. For instance, if patients suffer from pre-existing peripheral neuropathy, and also for particular patient populations like frail or elderly patients. What are the factors that can impact the tolerability? Of course, patient-related factors, and I'll come to that in a moment. Treatment-related factors like toxicity from previous treatment, and disease-related factors. For instance, if patients have a poor bone marrow reserve due to extensive involvement of the bone marrow by myeloma. So what are the considerations regarding patient-related factors? Well, we're dealing with a heterogeneous group, and 2/3 of the myeloma patients are elderly than 65 years. Some of these patients will be fit, but some very elderly patients might be very frail. Many patients can suffer from comorbidities, especially if they have received already many previous treatment lines. And then, of course, there can be disabilities that preclude the treatment with some of the current regimens. Toxicity should not only be expressed in terms of adverse events, but also in terms of quality of life. So therefore, it is important, in addition to adverse event reporting, also to monitor the quality of life. And currently, there is no consensus regarding which functional assessment scales to be used in elderly patients. So therefore, one could try to make some recommendations to improve the tolerability of the treatment. First of all, start with optimal regimen selection. So we cannot make the statement that one size or one treatment fits every patient category. Additionally, with a particular regimen, it can be necessary to modify the dose, the schedule, for instance, to go from a twice weekly to once a weekly administration of bortezomib, and also to optimize the route of administration. And in addition to that, one should not forget about optimal supportive care in order to prevent infections or to give appropriate thromboprophylaxis when using IMiDs in combination with steroids and or with chemotherapy. So now I would like to ask some questions on treatment tolerability to my distinguished faculty. So my first question is to Dr. Ludwig, and this question is, which assessment would you recommend for elderly patients before starting anti-myeloma treatment?
So this is a difficult question because there is no widely agreed consensus about which instrument should be used. But what is clear is that we have to assess the performance status, and we should assess morbidity, comorbidity, and the question is which instrument should be used. There's a Charlson instrument, there's a Kaplan-Feinstein instrument which is available. There are other instruments which have been used, but not so much in myeloma. So we should assess comorbidity, frailty, and disability, and these different issues of impaired quality of life are sometimes overlapping, so that is a problem. In addition, we have to assess, of course, renal function, which is very important. We have to assess pre-existing neuropathy, and there's an instrument which has been produced by the FACT GOG group. It's very important to have the patient do the assessment, so self-assessment is important by the patient. And we should also have a look at the bone marrow reserve, which is difficult, but many elderly patients come in with some mild signs of myelodysplasia, so that may also be an important information. And of course, the cardiac respiratory function should be roughly assessed, but that can be done on clinical terms.
Okay, thank you, Dr. Ludwig. So now I would like to ask a question to Dr. Nahi, and we already heard about assessment of peripheral neuropathy, and especially when treating with thalidomide or bortezomib, it's important to measure peripheral neuropathy. So my question is, how would you do this in clinical practice, and also how frequent would you assess the patients?
Well, principally, I do discriminate, if I have to say so, younger patient against elderly. You know that younger patient in induction, they have a short treatment time, and probably one should accept grade 3 neuropathy, because you know this treatment is lasting and the patient will go further on to high dose treatment. Using thalidomide or bortezomib for younger, I probably accept more neuropathy with bortezomib, knowing that a lot of these will go back, will recover, but less in thalidomide, knowing that thalidomide neuropathy may be long-lasting. In elderly patient, I usually monitor that every cycle, just to know that the patient won't get a grade 3 neuropathy, and try to stop the treatment or reduce the dose, both in bortezomib and thalidomide.
And in terms of assessment, would you use these more complicated specialized neurotoxicity scales, or would you rely more on clinical assessment or on an in-house questionnaire?
Well, in daily practice, it's never possible to have a very advanced scale to fill in. I try to depend on my clinical view, and try to educate my nurses also to talk to the patient every time they get a shot of bortezomib, or every time a patient with thalidomide is in the clinic, and monitor them more careful than younger patients.
Do you believe there is a role for specific neurophysiological tests to pick up neuropathy?
Well, I don't think so. In the beginning, when we didn't that much about the neurotoxicity of thalidomide and bortezomib, we were desperate to know. But we know now every myeloma doctor can grade neuropathy from 1 to 4, and time-consuming, and it is not a daily practice. I don't think so.
Okay, thank you very much. So we heard a lot already about bortezomib sub-Q administration, and that it results in relapsed patients in similar or nearly identical efficacy compared to IV, but better tolerability. And so my next question is to Dr. Udvardi. And do you believe that sub-Q administration has now become, or will soon become, the new standard for all myeloma patients receiving bortezomib, or only for particular subgroups?
I think so, that it is really a major step forward, and clearly due to the different pharmacokinetic properties, missing the early sharp increase, peak level in plasma concentration can result in a substantial reduction of polyneuropathy. And maybe many or most of the patients would benefit from that, especially the elderly, frail, or background polyneuropathy patients. But there are certainly other groups in which I would be very cautious in my assumption. For example, in an aggressive disease form like plasma cell leukemia, either primary or secondary, or if you have unusual form of myeloma, for example, plasmacytoma, you should be more cautious and see what are the results, and not switch automatically. Another issue can be if the young patient induction therapy could be automatically switched or not. Probably this should be also investigated before making this decision.
Anybody else from the faculty want to make a comment on this important question?
I agree too. For younger patients, for example, if you look at Velcade-based induction regimens, the need for sub-Q Velcade is not exactly the same because basically these patients have to come to the hospital. So you may say that it might be sub-Q bortezomib might be more important for elderly patients, for example, as compared to younger patients, transplant-eligible patients. But and you may have the same approach for plasma cell leukemia. But if you say that plasma cell leukemia patients have to receive IV bortezomib, you basically accept the fact that IV bortezomib is better than sub-Q bortezomib. So that's not. I think it's a little bit confusing as well. So I would say that basically what we have is that the efficacy is the same, and we have to accept that the efficacy is the same. One practical point is that for younger patients, the need for sub-Q in the context of the induction is less. Mm-hmm. But otherwise, what we have in hands is that the both route of administrations are effective, in fact.
I think
the need for our patients is probably the same. For our nurses, is not the same.
It's not the same.
It's clearly more practical in the house.
That's true. That's true.
So the reduction in the frequency and in the intensity of peripheral neuropathy is important and probably will pay off because you can keep your patients longer on bortezomib, or when you reinstitute treatment, you start at a lower level without any neuropathy again. So I think that is an additional value which is provided by the sub-Q administration form.
But I think we will be using both, in fact, because, for example, we have 5-6% of patients who develop severe or some significant cutaneous toxicity with sub-Q, and these patients will have to go back or to switch to IV. So in your hospital, you will have sub-Q and IV. What will be true is that you will have a lot of patients on sub-Q and few patients on IV, but you will have both, in fact.
Okay, thank you very much. So, of course, sometimes we need additional approaches to try to improve the tolerability, and one of these approaches could also be to modify the dose, to reduce the dose. And so therefore I would like to ask Dr. Boccadoro, for instance, if you treat a patient with lenalidomide, dexamethasone, can you think of particular situations where you would like to reduce immediately already the dose in order to optimize the treatment?
Okay, thank you. The dose modification, of course, can increase the tolerability of the treatment, but there are rules that you have to follow. And for instance, using lenalidomide, it's important to maintain the original dose for at least 12 months because you have to balance the efficacy and the tolerability, and probably during the induction phase it's important to maintain a higher dose. After 12 months, the decrease of the lenalidomide dose is important because it's improving the tolerability. So as a total, the survival of the patient is better if you maintain the dose during the first period and then you reduce. But I think that this is not unique for lenalidomide. I think there's some sort of general idea that you can use also for the new other novel drugs, that at the presentation you have to give the more effective treatment, and then you have to maintain with novel agents that are not chemo, so it's a different attitude to the treatment.
So if, for instance, a patient would present with poor bone marrow reserve due to extensive myeloma involvement, do I hear you say that then you would go for the full dose with eventually GCSF support, or would you start with a lower dose and try to escalate later on when the bone marrow function recovers?
I think that this is a matter of discussion. A patient with a plasma cell leukemia with reduced bone marrow function that will start with a full dose. In 85 patients with reduced reserve, I think that's a good idea to start with a really small dose. I mean, it's a medical problem.
Thank you. So, and then a third approach could be to modify the schedule. And for instance, we have the standard VMP with bortezomib twice weekly, and we have also the VMP light or VMP modified. Dr. Facon, could you think of particular patients where you would immediately start with a more reduced VMP regimen?
Yes, that's an important point. And as you said, we started with the IV twice weekly in the VISTA schedule, and we moved forward with the IV weekly, and you may also need some dose reduction, and we will end up possibly with the weekly sub-Q. So VMP has been a somewhat evolving standard of care, and it's a little bit different for MPT, for example. We had dose reduction for MPT, but it has been an evolving standard of care in terms of schedule modifications. And here we have, so the weekly schedule, the IV weekly schedule has been investigated in Italy and in Spain, and basically the core treatment is bortezomib IV days 1, 8, 15, and 22. And but as you know, in the Spanish trial, they started with a VISTA regimen. The first cycle was a VISTA-like schedule, and it was not the case in the Italian study. So we may say, and I think it's what we are doing in my country, if you, and it's in line with what was said by Mario, if you have patients, if you have patients with very severe disease, with symptoms, with pain, with renal insufficiency, you may want to start with twice weekly bortezomib. In contrast, if you have a patients with few symptoms, for example, you may start with the VMP weekly. So, okay, if you have plasma cell leukemia and you want to start VMP, for sure we would recommend to start and maybe to keep patients on the twice weekly schedule. So, I think it's part of life, and it's very interesting to see that the VMP has been such an evolving standard of care, and so these alternative schedules have the same, basically the same or quite the same efficacy and a better tolerance, in fact, as compared to the twice weekly.
In that regard, can I just challenge you with another question? For instance, because you mentioned it before, that for some patients you would select a sub-Q administration. Would the fact that we can give bortezomib sub-Q, for instance, make you change that you say, by IV I would give the bortezomib only once weekly, and now since I can give it sub-Q, I might start with twice weekly? Would that eventually impact your
No, I think if we accept the fact that the sub-Q is as effective as the IV, it's the same issue. But we would agree to say that we would like to see additional results with weekly sub-Q, just to make sure that it is as effective as the IV, and so that will be more comfortable for physicians, in fact.
Thank you very much. So I think we can conclude maybe by saying that in the previous lectures we heard that thanks to the novel agents and novel treatment approaches, the overall survival has significantly improved for transplant candidates and for elderly patients. But therefore it's so important to try to maintain the quality of life by optimizing the treatment tolerability. And we heard that there are several ways of doing this, by selecting the optimal regimen, by eventually reducing the dose, prolonging the treatment interval, and importantly also for bortezomib by changing the route of administration. And with this, I would like to thank my distinguished faculty for this interesting discussion and for their contribution. Thank you.